Hello and welcome to Legislative Report. I'm State Representative Judy Ward in the 80th District in Blair County. I recently had an opportunity to meet a physician who is committed to making a difference. Dr. Zane is focused on providing medical care for the working poor. In collaboration with hospitals, a Penn State professor, and an insurance company, Dr. Gates has created a clinic-based system to provide basic health care and an affordable hospital-only insurance plan. Dr. Gates met with the Speaker of the House, Representative Mike Turzai, and I to explain how this model streamlines the system, providing cost savings and quality care. I'd like to share portions of our conversation with you now.
A family of four, and you have a wife who works at the cafeteria, and you're sick. Now, you don't know where you belong. Now, you've called around, you can't find anything, but you're diabetic, you haven't had a care in years, so you come to us. The first step is, what is nice, we're gonna find where you belong. So we come back here, and in this office here, this woman, Sonny, she takes your income information. The current system, you go to the Medicaid office, or you call around. We get you in here and she finds out and assesses you and says, boy, he's really out of control, we need to see him today. We don't care what his insurance rate, we'll work that out later. He needs the care today, because if he doesn't get that care, he's gonna end up in the emergency room with a stroke, cost the system $100,000, and more importantly, he's not gonna be there for his family and be a productive person in society. So she decides that. See, that's the difference. The neat thing is now people go to the Medicaid office and then they get a card and they have nowhere to go. Almost 70% of the physicians in general in the state don't take it. If you just do the rural, if you add in the inner city, it's 55%. But most of Pennsylvania is a rural state, so a lot of these people have no place to go. In our town, there's only 2 places now that are taking new patients and Medicaid patients. So it's a crisis, because we expanded Medicaid, now these places have nowhere to go. And you've changed the face of the people that expanded. These are the working poor now. And that's what's important. These are important that are paying taxes, busting their butt, and you give them a card and they're not treated the same. They call around 20 places and they have nowhere to go, which I think is a great social injustice.
Really nowhere to go?
Nowhere, no primary care physician can take them. And you can't blame them, because for what Medicaid pays and the bureaucracy and the difficulty to a physician practice, we estimate if a physician takes as much as 10 to 12% of Medicaid, they won't be able to pay their bills. It costs a physician $70 to see somebody. Even with the enhanced payment, they're getting $50. No business could stay open losing, 20 bucks on everybody they see.
Right.
And this is statewide. This just isn't in Altoona. This is statewide.
Okay.
You do a little better in the inner city and statewide. But our system is different. Not only do we get you somewhere, we have a new care model.
Did you know that there are 6 ornate bronze chandeliers hanging in the House chamber? The 4 large chandeliers are estimated to weigh 3 tons each. Yet these iron and brass fixtures, painted in 18-karat gold, manage to dangle effortlessly. It takes 168 light bulbs to light the large chandeliers and 84 light bulbs on each of the smaller chandeliers. As you can imagine, changing the light bulbs when they burn out is far from easy. Workers must build scaffolding in order to reach their 1,450 light bulbs. Today, special, long-life, low-wattage energy-saving bulbs are used to lessen the amount of times that the light bulbs will need to be replaced. Now you know. Did you know that the state capitol is not only the epicenter of the Commonwealth's governing bodies, but was once home to 390 preserved Civil War flags? During the war, it was customary for each state to furnish their regiments in battle with flags representing their contribution to the Union Army. After the war, Pennsylvania's military department was responsible for collecting the flags, and in 1872, they were reverently housed in the Capitol. Following the completion of construction on the new Capitol building in 1914, the Civil War flags were moved to the Capitol Rotunda. They were kept untouched in custom-made flag cases until 1982, when the Capitol Preservation Committee initiated its Save the Flags project. Throughout the years, dust and long-term vertical display of the flags had begun to devastate the brittle silk fabric and painted designs. The flags were removed by local textile conservators and were repaired and preserved in storage units that protect the relics from light, dust, and excessive handling. Now you know.
Since we don't administer, the deal that we will have with the UPMC health system is it's completely insuranceless. No billing, there's no prior auths, there's none of all that administrative bureaucracy is gone. So now we can afford, since physicians now spend $188,000 per physician just on insurance administration. Nurses are spending 88%, upfront people are spending 88% of their time doing nothing but insurance. Nurses are up to 50%. How are we going to take care of people? Physicians, it's 14%. So it's very difficult to take care of people when you're embedded by insurance. So this nurse here, Carol, is going to come in and she's going to ask you your problems. Here's Carol. She's worked here forever. She's
Hello.
forever.
Very nice to meet you.
What's different now?
Very nice to meet you.
Mr. Crayon.
Nice to meet you. Yes, Mr. Crayon. Yes, I see no
She's going to
schedule.
talk about your diabetes because you haven't been seen in a very long time. Remember, you're on a hot roof working every day, doing everything right, because I say, a roofer, there's a lot of honor in being a roofer. And I think that...
I do think you should name him Mr. Fiddler.
Okay, we can do.
So
we
this
can do
nurse
that.
is unembedded
Okay.
by insurance bureaucracy. So her only focus is on you. So he hasn't been cared for in a year, and he's on 5 medications which he hasn't been taking. He's not sure he has been taking.
Okay.
His sugars are way out of control. They've been 500. He's been peeing a lot. He's been
Okay.
thirsty a lot. So I think the best course of action is to get our pharmacist to see him.
Okay.
The new wrinkle in this whole thing is the care model. The first person to see the patient is the pharmacist. So he comes in. My biggest thing, I used to be a pharmacist, is, they're always taking the pills from the big bottle and putting them in the little bottle. And these guys are educated for 6 years, and they know so much. On average, our pharmacist has saved $9,000 a week by debreeding medications, by catching interactions, by telling us that people aren't even picking up the prescriptions. So he's going to talk to you a bit about your diabetes and your medications.
Zane, you call that the CARE model? Is CARE an acronym or just the descriptor?
Just a descriptor.
Okay.
Yeah. You ready, Pete?
Okay, I'm ready to go.
So she's checked in,
Yeah,
took
I've
your blood
checked in.
pressure, got
Yes.
your weight, figured out what's going on, you assessed you. But
Mhm.
again, the key is this is a relationship model. In the current system, everything is so rushed because she's got to worry about all these regulations with the ACA. She's got ICD-10 codes, and she's looking at you depending on what insurance you have. If you have insurance A, you need this stuff. You have insurance B, you have this stuff. You need someone just to listen to you. You're scared, you haven't been treated, you have the pressure of I have to get back to work because I got 3 kids that need fed, and I got a wife that's working her butt off. So you need somebody to take time. Plus, they don't have the highest education level. Doesn't not make you a good person, but you don't have the highest education, so you don't understand a lot of these things. She's able to take the time with you and get your whole story because she's not rushed by the whole advent. Now in comes Pete, the pharmacist, who's going to talk to you.
Hi, I'm
about
Pete
your-
Krekel. I'm the clinical pharmacist here.
Right.
Mike, nice to meet you. You came to our clinic today. You were referred because of your diabetes, and you understand what that is? It's out of control blood sugars. Your pancreas is what governs your blood sugar levels in your body, and what happens is when it's under stress a lot, you push harder and harder, and the pancreas just becomes tired, and that's where we are with you. So there's some medications that we're going to give you. They're going to be inexpensive medications. We know that you are uninsured. You were just referred to us, and because of these medications being so affordable, it's going to stave off the disease. So the first one that Dr. Gates has put you on is the metformin, 1,000 milligrams. And the side effects you take twice a day. Make sure you take it with food to minimize the stomach upset, breakfast and supper. And what that does is it helps your body better utilize the insulin that it's already making. We're also going to have you on another drug called Amaryl. And that drug, what it does is helps push out more insulin from the pancreas. Right now, what we're trying to do is keep you away from insulin. Insulin, when we have to do it, we're very comfortable doing it for now. We want to get you a good dietitian consult so you can eat better with foods you can afford and take these medications. I also saw you're on Benicar, which is a $175 a month drug, and since you've lost your insurance, you're not going to be able to afford that. So I'll talk to Dr. Gates for you, and maybe we can get you switched to irbesartan. It's a long-acting drug in the same class. It'll protect your kidneys. It'll also lower your blood pressure and keep you underlying. Okay? So what I want you to do before you leave here, because you are going to be on some medications that are going to lower your blood sugar, is to know the signs and symptoms of low blood sugar. And I have this graph. And I would take like 10 minutes with you, Mike, to go over all of this. And if you get, these are the symptoms you've had already with high blood sugar, okay? And once we get you on your blood sugar medications and better get it under control, there might be a chance that you would have too low blood sugar. So these are the armaments that we're going to use to combat low blood sugar. And then I would go through too under like normal pancreatic function. And you know, this is a normal level. I use this a lot with the insulin patients. When we start somebody new on insulin, I explain to them why they need 2 insulins. And what I bring to this picture really is the cost savings. You know, I know what's cheap and I know what's expensive. I can tell you that the Benicar is $175 a month. I can tell you irbesartan $6 or $8 a month, and it's the same thing. So I see all the patients before Dr. Gates does. I always talk about adherence. I don't say, are you taking your medications? Everybody says yes, right? I say, in the course of a month, Mr. Turzai, how often do you say you miss a dose? And if you think, gosh, I miss half of them, I'd say, well, I had pill reminders that I'd bring in, give you one of those, and we preach adherence. You know, C. Everett Koop said we have great medications, but they're not doing anybody any good if you're not taking them.
Yeah.
So that's a big thing that we do. You know, metformin is, $5, $6 a month. Amaryl's $5 or $6 a month. But if they are remaining in the pill box, or like 47% of the prescriptions 6 months later are never even picked up at the drugstore, we got a problem. So I'm a retail pharmacist, and then I'm here a couple days, well, 1 day a week now, hopefully a couple days a week, and I am able to bring to the table the cost savings analysis as well as, the pharmacology expertise. These guys are the diagnosticians. I know my role in this. It's amazing what they're able to do for patients, but I bring the pharmacology to light.
Now,
Thank
Pete,
you.
Pete,
Real
you've
pleasure.
put together a formulary for the
Yes.
clinic.
Yeah, we did a formulary. My wife is a pharmacist. My son-in-law is a pharmacist. My daughter's a pharmacist. And we put together this formulary. And Dr. Gates, at a picnic we met, he says, you've got to help me. He says, I want drugs $5 and less. You can't believe the diseases this guy can treat with $5 a month
amazing.
medications.
Yeah.
It's amazing.
It's because it's a collaboration.
Yes.
Mm-hmm.
And the big thing that's
Right.
nice is if you look at, I've got all the data from UPMC for you, and what Medicaid is spending per member per month is compared to
Thank
at the
you.
same age group as compared to the regular commercial market. They're spending $206 per member per month on medication. The regular market's doing about 80 to 85. So is Medicaid a sicker group? Yes, but the reason why they're a sicker group is because they're not cared for and educated. And it's the truth. Everybody has this misconception of Medicaid being a bunch of malingerers, and it's not true. 15% of the people that are caught in a cycle of poverty and have no incentive to work. Then if you look at the rest, the 20 to 30% are all the disabled, the mentally challenged,
Right.
and those things like that. And then this now you've got a whole new 30% of the working poor, the part-time Walmart now, the roofer like yourself. These is the new face of Medicaid that now are being denied care. So when I come in to see you, since I'm not impeded, everybody's treated the same. And when we have the commercial people, and we're going to expand this across the state, I see no difference between you and a Medicaid patient, because you're going to have the same formulary, you're going to have the same thing, everybody's going to get the same care. Because, I'm sorry. So now, me and you've talked, okay, now we know you're diabetic, and we know you haven't had care for a while. We're going to work out how this is going to work out. You probably qualify for Medicaid. She just looked at your income information, so we're going to get you on your Medicaid. How about getting your wife here? Is your children covered? because we'll help you get them all covered too. That's the nice conduit. We send people to the welfare office when they need to come to the doctor's office to get the care, then work out everything, because it's better for the system, and that's what we do.
You've been watching my meeting with Dr. Zane Gates. Let's take a short break. Legislative Report will return in a moment.
Did you know that Violet Oakley was the first female artist to receive a large commission for artwork done in a United States Capitol building? In 1902, Joseph Houston, designer and architect for the 3rd Harrisburg Capitol building, commissioned Violet Oakley to paint murals for the governor's reception room. He believed that Oakley's contribution would add interest to the building and act as an encouragement of women of the state. Prior to beginning her work for the Capitol, Oakley set out to England to conduct research for her murals. Upon return, she decided to center her artwork on William Penn and the founding of Pennsylvania. Oakley made sure that Penn's ideals of justice and peace could be seen throughout her work. In 1906, she completed 13 murals titled The Founding of the State of Liberty Spiritual and was placed in sequential order around the governor's reception room. These murals were some of the first to be installed in the Capitol. When Edwin Austin Abbey, another artist for the Capitol, died in 1911, Oakley was offered another opportunity to create murals for the unfinished Senate and Supreme Court chambers. Her work on the Senate murals, including International Understanding, was completed by 1919. Oakley then completed the Supreme Court murals, including the Divine Law, by 1927. Oakley is said to be the principal artist for the Capitol, with a total of 43 murals on display. She remains one of the greatest muralists in the United States. Now you know.
Because again, it's a team approach. And he's an uncontrolled diabetic, Megan. He hasn't had his medication in a very long time, and his sugar's way out of whack, and he has no idea how to eat.
Okay, so sounds good. You'd come to the clinic, and what we would try and do is have you see me the same day. That way you wouldn't have to actually leave and come back.
Right.
So you'd come right across the hall over here, and I would first go over your labs with you one more time to see if you had any questions. That way it's just you and I sitting down, going over them one-on-one. From there, we'd review your medications to see, do you have questions? How often are you checking your blood sugars? Do you know how to check your blood sugars? And then from there, we'd get to the diet. So you would tell me, how do you typically eat in a day?
Right.
What kind of foods do you like? What kind of foods don't you like? Do you have access to foods? Are you going to the food bank?
Do you actually plan out the meals?
Yeah. I give them, if you're a diabetic, we come up with what's called a carb-consistent diet, and then from there we kind of make up meals and discuss what kind of options you have in terms of choosing your carbs. So
But don't you start with asking his appetite and so you get something that works
Well-
for him, that he's going to be interested in?
typically, our patients here typically don't have problems with appetite. I do a full nutrition history recall with them. I would ask you things about like your weight history. Has your weight been stable? So right there from that question, if you told me I lost 20 pounds, I would say, was that intentional, unintentional? So I would get an idea of his appetite from that.
But I meant in terms of food choices. So, I mean, you're not going to prescribe him broccoli
No.
if he
No.
doesn't like broccoli.
No, that's why I
For
do
example.
the 24-hour recall, so I can get an idea, like, let's say he never has a fruit or a vegetable all day. I would ask, do you like those types of foods? Why are you typically not choosing them? And then from there,
Right.
you would say, I can't afford them, or I'm a picky eater and I don't like those types of foods. And so then we might talk about different ways to prepare them, or different ways to eat them with sauces or dips, so that you would hopefully start to get a taste for them.
Yeah.
Also, I have vouchers to the farmers markets in Altoona, so then I give them vouchers so that they can get free fruits and vegetables so that they can taste things. A lot of times people don't eat zucchini because they don't know what to do with it, so then I can give them recipes.
I would be one of them.
Yeah, so then I would give them recipes, like
My
right now
wife
the farmer's market has zucchini and this is what you can do with it. And so, yeah, I do try to tailor it towards them because everyone that comes here is so different, and I have to really individualize it because you have the person that doesn't like fruits and vegetables, or you have the person that does like it but can't afford it.
Yeah.
So,
And here's the thing, that in the current Medicaid system and in the current insurance world, her visits are limited. Here, this is like the pill. This is like taking medication.
Yes.
It's included in the it is
Right.
part of your treatment plan.
Right.
It isn't something that you're going to bill a new ICD code and you have 5 visits, and you may need 10 visits with her. You may need 20.
Right.
And it's not just, okay, I went to the dietitian, it's done. No. The dietitian is integrated in your care from day one, the whole way through your care process.
Yeah.
Because it's not a sprint. Everybody does this. Oh, I'm a diabetic. Oh, they're working out. They're lifting. Oh, I'm eating that. And then 6 months, they're back to eating lard and doing
Right.
all the other
No,
things.
right.
The same thing that they were doing that were unhealthy. We believe that it's keep reinforce. You're talking generations, of poverty, and they want the high carbs, the quick fix, the things that give value.
Yes.
We want to change behaviors, and we have.
Yeah,
the
we
papers
do
that
lifestyle
we
changes, very small, obtainable goals.
Yeah.
And like Dr. Gates says, I'll see someone once a month for 6 months. They're doing really well. I'll check on them a year from now. What's their weight? What's their A1C like? If it looks like they've regressed, I'll call them and say, do you want to come back in? Do we need to
Yeah.
talk?
And then we, twice a month, and soon it'll be weekly, have team meetings. Me, her, the nurse manager, the pharmacist, and soon the psychologist someday. And we get the toughest patients, and she's the team lead, and we go over together as a team the best ways with all our interventions how to do this. This isn't happening in a lot of primary care offices because they're impeded by the insurance, all the things that they have to do with the ACA. We don't have to do any of these things. And this is the conduit to our success. If you're acutely ill, we will have 20 of the most commonly prescribed drugs that we'll be able to give you right on the spot. That lowers the cost because that's included all in the capitation cost. So is the lab. So 95% of all the labs you will need will be done here, ran here. That's included in the flat cost of the price.
Yeah.
So you don't go and get the lab and every time there's a bill here, there's a bill here, there's a bill
Right.
here, there's a bill. Every time you do a click, I figured out, every time you transmit a bill, let's say a simple bill for a lab. Okay, so has to go to the hospital. Then the hospital sends the lab to the bill. The lab sends it to the billing office, which then sends it, which costs money, which then sends it to the insurance company. The insurance company reprices it goes to the
Right.
the
Doctor, are you
broker.
the only one with this model? I mean,
Yes.
seriously, and why is UPMC willing to take a gamble on you and not anybody else?
Well, because we have a lot of hard data.
Yeah.
We have 4 published papers. We have a track record. We've been doing this for a while. And there's a crisis mode in this soon to be with Medicaid patients. The ER visits of Medicaid patients have gone through the roof. Oregon has clearly showed us that all that money that they spent, they got a flat rate, they got the waiver and everything like that. It didn't improve in outcomes, only in mental health, but all other outcomes, diabetes, they didn't do well. Just a new paper came out that no change in obesity with Medicaid expansion. We are focused on the wrong thing, how to expand insurance. If you look at Jonathan Gruber, who wrote it, he used just a microsimulation model that was just designed just to score it by the CBO
Right.
and was only focused on expanding insurance, not
Right.
improving care,
No, I
things
get
like
it.
that.
I get it. And the last thing, and I apologize, we probably have to wrap up, but you're focused on provider care, a team provider care and outcomes. Are you tracking your outcomes?
Yep.
And how do you measure?
Well, we compare ourselves to the regular practices. That's how
Right.
we did. The first paper we wrote that got published in a journal out of the Mayo Clinic, the Journal of Primary Care and Community Health, we looked at admission rates per provider against all the providers in the 2 biggest groups, mainline medical and BMA of primary care. And we found that we admitted half as many people to the hospitals compared to them. We also compared ourselves against the community health center, because that would be more equivalent, because the
Yeah,
community
yeah,
health center.
population,
And
yes.
we found that, and this paper is going to be coming out, we cut hemoglobin A1Cs half as much as they did, weight by 80% more, and blood pressure by 38% more. So that's how we measure. We feel we measure around the people in our market, because the demographics of the people are going to be the same.
No, that makes sense. Yeah. Well, I can't thank you enough. I mean, I understand the issue is not only your Medicaid population.
No, we're going to do it for the underinsured. We're going to expand this into all
I mean,
markets.
folks like myself, like, you know, we're on the road all the time, you're busy, you're worried about your job, your kids. You're the last person you're thinking about yourself. And you need, before it gets too late, to track the things that you need to do in terms of your lifestyle.
The speaker's wife is a pediatrician, so
This
is a whole- this is great.
and you've done TED Talks for John.
Yeah, I did a TED Talk about it.
Yeah. Oh, did you do a TED Talk?
For Johnson
Oh, wow.
and Johnson.
That's amazing. Yeah.
And you're coming out with your 4th published paper, correct?
Yeah.
We really believe that this
Is
could
anybody else replicating it?
Well, we plan to replicate it. We want to perfect it, and then we plan to replicate it in Indiana County and Westmoreland County.
Is it affordable from the insurer's perspective?
Oh, yeah. It's a lot cheaper.
Because your upfront costs are driving down the follow-up costs.
But our upfront costs are cheaper because we eliminated insurance. The administration that costs, you don't have to hire a biller. You don't have to do a re-adjudication of claims. You don't have to have all these extra nurses.
But does UPMC do that for you, though? I mean, because you are still, like, if you get them on Medicaid, there's some paperwork involved, right?
The health plan does that.
Yeah.
But we don't have to do any of that other stuff.
You don't do it.
Yeah, we don't
Yeah.
do it, which drives our costs down significantly.
Right.
This whole operation, we hope to be the capacity of 3,000 to 4,000 would be $770,000. You couldn't do that in any price.
How many people do you, on an annual basis, come through the clinic?
About 5,000 visits. That's how many we have. But that's going to really expand now that we've partnered with UPMC. It's a partnership. It's not just the government. It's a partnership.
Yeah.
You have private investors. You
Right.
have the hospital investing. You have the health plan investing in
And your care.
your care.
Yeah.
And
You're
it's,
the key component.
well, no, it's
I mean, your team is.
the team,
Yeah,
and
yeah, your team is the key
but there are
component.
going to be other teams, and we
Right.
hope that, selfishly say, boy, we hope we're the only one, but for the best of our, other people will catch on, and this will spread, because this is the conduit to how we get care. Right now, if you see when I spoke in my TED Talk, we designed the insurance, then wrap the care around it. Now we designed the care, and then wrap the insurance where you need it.
That's all the time we have for today's program. I'm Representative Judy Ward. If you have any comments or questions about any state matter, please contact me at my local office or through my website. That information will be shown in a moment. Thanks for watching, and please join me next time for Legislative Report.